Dr. Stone, the Academy has come forward with a set of recommendations with regard to genetic testing for AMD, and you presented your summary of that. One of the questions that we've had from people out there is, to what extent does one want to promote the development of new genetic tests that may be more sensitive, more specific, and more helpful, at the same time as giving people a very clear indication of what the limitations of the current testing are, and putting forth a position that you currently put forth that people should not have genetic testing willy-nilly?
Well, I think the interesting aspect of your question about the development of a test is, let's just put it in the context of the development of a drug. Right. Would someone think that it was okay to advance the notion that a certain compound might help, sell the compound to the public, follow the people on that while selling it to them for a number of years, right, and through that mechanism look for new drugs? No, you would say that a company would need to do research. They would have to have a hypothesis. They would have to test it in populations and show that it worked. And then once it worked, they would deliver that as something that would be useful for caring for patients. In this case, there are some genetic associations with age-related macular degeneration which are absolutely valid. They're very strong. There's nothing wrong with those. And some companies have decided to market tests of these associations as a means of assisting physicians in caring for their patients with no evidence that the results of those tests actually assist the physicians in the caring for these patients. And so you'll see that in the AAO position statement, it says, for now, this sort of testing should be confined to research. That's like saying, for now, this sort of investigation of the drug should be confined to research until it is proven to be of benefit. I'm a geneticist. I believe in the power of genetics. My lab works in genetics, and I believe that ultimately the evaluation of genotype will find its way into the practice of medicine. But when it's going to find its way into the practice of medicine is when there is a specific intervention that one can use in people with specific genotypes. That's when this genotyping is going to be helpful for the practice of medicine.
Okay, and that leads into my second question. In your particular lab, what are the most promising candidates? In terms of genetic loci?
Well, I think that there are a number of genes that have been shown by laboratories around the world to be associated with macular degeneration. So it isn't that one locus or the other is promising for making a better test in my mind. I believe what the question is how can we take the known risk factors and use that knowledge to develop a pharmaceutical or other means for intervening in those very strong pathogenic mechanisms. So I don't believe that the research edge, if you will, of this issue we're talking about right now lies on the side of the genetic test. I think the research edge of this question lies on the development of the effective intervention that is based upon the genotype. That's what's missing from the equation. Right now, we have one very powerful intervention for macular degeneration, which is an intervention for neovascular disease. As I've shown you today, the genetic tests really don't speak to that complication at all, and so people need to be monitoring their vision daily, seeing their doctor periodically and so forth to detect that risk, that event, so that they can receive that treatment. The other effective interventions include avoidance of smoking and certain nutritional interventions, which apply all across the board of all people with well, no one should smoke, period, but all people that have a moderate amount of dry AMD, studies have shown that they benefit from nutritional supplementation, regardless of their genotype. So right now, those recommendations are all across the genotypic spectrum, and you don't need the genotype to help you. So to restate that, the thing that is going to bring this genotyping into real utility is when there is an intervention that is altered by the knowledge of the genotype, which we do not have today.
So what you're talking about are translational approaches, looking at what you have and translating it from the lab to the clinic. What are the current impediments that you see in that area? Obviously you can divide them into technical, political, clinical. What would you say is your greatest challenge of those three categories?
Well, I think that I guess I'm very, obviously the disease is a challenge, and it's always challenging to do translational medicine simply because it's hard to be both a physician and a scientist in this complicated world that we live in. But I would think about it much more optimistically. I would think that, talk about it in a positive way, in that translational work is ongoing in a number of centers very effectively. Large trials, large studies like the Age-Related Eye Disease Study and the Blue Mountain Study that we've spoken about today are studying patients very carefully, and we're learning about how the disease behaves. Laboratory studies are understanding the mechanisms of these diseases better and better. So I think that we sort of need to stay the course, meaning keeping all of those kinds of things aggressively underway, and simply not call the question too soon and say, oh, well, now that we can find a very statistical association between this locus or that locus and the development of AMD, now we'll just test the patients and we're done. We're not done. We don't have the intervention yet. And what we need is the Lipitor of AMD. Okay, we need the drug that is going to interrupt this pathophysiologic mechanism 10 years before the person loses vision. And we need to recognize the people that would benefit from a drug like that, and we need to get it to them.